Hi everyone, welcome back. I want to continue with fluid and electrolytes, and I'm going to finish up with calcium. So on the handout, the third electrolyte is calcium. The fourth is phosphorus, which I won't go over, but I want you to make sure you read it and you understand the concepts related to phosphorus, and keep in mind that it has an inverse relationship with calcium. So similarities as far as hypophosphatemia, signs and symptoms are going to be very similar to hypercalcemia and vice versa. And then the last one is magnesium, very self-explanatory. It should just be a review for you. Very similar as far as symptoms related to calcium. Hypomagnesemia is similar to hypocalcemia, and hypermagnesemia is similar to signs and symptoms of hypercalcemia. And then just make sure you know the treatment. So let's just go ahead and finish up with calcium. Acts like sedatives on muscles. That's important to think about because that helps with the side effects, or excuse me, the signs and symptoms. So calcium, when it increases, it kind of causes the muscles to be sedate and not move. Most abundant electrolyte in the body has an inverse relationship with phosphorus. Super important to know. If you don't know that yet, know it now. Necessary for nerve impulse transmission. So all of them are helpful for nerves. Blood clotting, calcium, contraction, calcium, cardiac. So calcium is one of the cardiac electrolytes as well. Clotting, muscle contraction. Muscle contraction for calcium, magnesium. We need to have a balance of magnesium. Magnesium promotes relaxation, and then we have that balance between the two. Promotes strong bones and teeth. Who needs extra calcium? Children, pregnant, and lactating women. Obviously, we must have vitamin D present to utilize calcium and absorb it. So when somebody's taking calcium, we have to make sure they have enough vitamin D as well, or their body won't absorb it. If blood levels of calcium decrease, the body takes calcium from the bones and teeth. And normal calcium is a 9 to 11. If we're talking about an ionized calcium, it's 4.5 to 5.5. And normal, okay, one thing I want to say about the ionized calcium, when we take ionized calcium, it does not vary with albumin levels. So 50% of calcium is bound to albumin. As albumin levels drop, if people become malnourished and protein levels drop, their calcium levels drop with it because the serum calcium travels around bound to albumin. But if we get an ionized calcium, it doesn't vary with albumin levels. And so it's useful to measure the ionized calcium level when the serum albumin is not in normal range. Sometimes there's a calculation, but just getting an ionized calcium can be helpful with that. Okay. So this right here is hypocalcemia, the serum calcium less than 9. What are some causes of hypocalcemia? Keep in mind, hypocalcemia is much more common than hypercalcemia. Think about it. You see this much more in a hospitalized patient, low calcium versus high calcium. Decreased calcium intake could be a reason. Renal failure, okay, that's important to know as well. So we know that when somebody has some renal failure, the kidneys cannot make vitamin D. So the kidneys play a role in vitamin D conversion. And without the vitamin D, the body can't absorb calcium. So they tend to have low vitamin Ds with renal failure and increased phosphorus with renal failure. So the kidneys don't excrete phosphorus. As the phosphorus goes up, calcium level goes down because they're inversely proportionate. Very important to know that. Vitamin D intake, if it's low, it's common in Ohio and some of the states that have winter, so vitamin D is required to absorb calcium from the GI tract. Diarrhea, calcium is excreted in the GI tract. Pancreatitis, we have talked about that. Remember, in pancreatitis, a cause of pancreatitis could be hypercalcemia, but a symptom of pancreatitis is hypocalcemia, because remember, the calcium combines with those fatty acids in the pancreas like detergent, and it pulls that calcium down. That's important to know as well. Obviously, hyperphosphatemia, as phosphorus increases, calcium decreases. Thyroidectomy, sometimes the parathyroid can be accidentally removed. And I talked about low albumin leads to falsely lowered calcium, because albumin binds approximately 50% of the blood calcium. Ionized calcium is still normal, therefore there are no symptoms. There are formulas to correct it if we need to. Alkalosis, just like when we talked about potassium. Remember, we said alkalosis causes a low K, causes a low potassium. Same concept with the calcium. We'll see hypocalcemia. What happens here when somebody goes into alkalosis, and think about like a respiratory alkalosis, somebody's just hyperventilating, the albumin becomes more negatively charged and binds to the positively charged calcium. So we get more binding of the calcium in the albumin. This can lead to temporary hypocalcemia. So as this occurs, especially in a respiratory acidosis causing alkalosis, we have temporary hypocalcemia. Try hyperventilating for 2 minutes and see if your fingers start to tingle. And that may have happened sometimes. You get sick and you're vomiting and you're hyperventilating, or you get scared and you're hyperventilating. You can start feeling your fingers tingle, or sometimes you can get spasms and tetany in your fingers. So I'm not telling you to do it, but you may recall a time where that's happened. Signs and symptoms of hypocalcemia: muscle cramps, tetany, convulsions. So when there's too much calcium, remember I said calcium acts like a sedative on the muscles? Well, if it's low calcium, it's the opposite of a sedative. So hypocalcemia, hyper symptoms, cramps, tetany, convulsions, okay? The positive Chavostics and Trousseau's side, we've talked about that before. Chavostics is when we tap on the cheek and there's a spasm in the cheek, like a sustained blink when we tap on the face. And the Trousseau's is when we put the blood pressure cuff on somebody's arm and they have a carpal pedal spasm in their hand. Just remember these. I don't see these a lot. It's not something we really see in clinical, but it's certainly a great test question. Chavostics and Trousseau's comes with hypocalcemia. These are tetany reactions. Hyperactive DTRs, and hypocalcemia, hyper symptoms. And cardiac changes, keep in mind prolonged QT intervals. Very important to know that as well. A prolonged QT interval with hypocalcemia. So I kind of think about this would be something I would get confused with. Like, what does the QT do in hypocalcemia? Hypocalcemia prolonged, or like I think about increased. So again, hyper symptoms, prolonged QT interval, decreased myocardial contractility. Decreased calcium causes hyperexcitability of muscles. Treatment: first, check the albumin level and correct it if we need to. Remember, the ionized level is the most important, not the absolute level. IV calcium: patient must be on a heart monitor, as this drug can cause the QRS complex to widen. So when we give any IV calcium replacement, we need to have them on a monitor. Vitamin D therapy could be helpful, and we want to teach them about increased dietary calcium. So often it's just somebody doesn't have a good intake. People sometimes are just malnourished. They're not eating very well. So we just want to replace it. Hypercalcemia, serum calcium greater than 11, not as common, but when somebody has hypercalcemia, you got to really kind of stand and take note, because there could be something serious going on. Hyperparathyroidism. So if there's hyperparathyroid, the thyroid is hyperactive. Excessive parathyroid hormone. Think about that. Parathyroid is overactive. Excessive parathyroid hormone that causes the serum calcium to increase. And this, I have 3 asterisks by it. It's probably the most common cause of hypercalcemia that we see in an outpatient setting. Hyperparathyroidism. Hypoparathyroidism, I should have that here. Well, I kind of do here, the thyroidectomy. So somebody who has hypoparathyroidism or parathyroid's been removed or not working would cause a hypocalcemia. Immobilization, calcium leaves the bone and moves into the bloodstream. Increased calcium intake, increased vitamin D intake, just increases the serum calcium. Thiazide diuretic. So we think about diuretics, keep in mind that loop diuretics, when we give somebody a loop diuretic, they lose fluid and electrolytes, all the electrolytes, okay, and the fluid. When we give somebody potassium-sparing electrolyte or diuretic, they lose fluid and all electrolytes except potassium. When we give somebody a thiazide diuretic, they lose fluid, all the electrolytes except calcium. So somebody who's on thiazide diuretics, especially for long term, we can tend to see some hypercalcemia associated with this. And another thing that I have asterisk, which is concerning, is there's multiple mechanisms as to why, but malignancy will contribute to hypercalcemia, more commonly seen in an inpatient setting, and especially when when cancer affects the bones, the calcium leaks out of the bones and it gets into the blood. Signs and symptoms of hypercalcemia. Kind of, I don't know if you've ever heard stones, bones, groans, moans, and psychic overtones. I mean, so there really are some specific things that you should know for hypercalcemia. Hypercalcemia, calcium acts like a sedative on the muscles. We have the opposite. Decreased DTRs, excess calcium causes a sedative effect and decreases the deep tendon reflexes. Muscle weakness, right? Sedative effect on the muscles. Kidney stones, we get stones, kidney stones, calcium stones can occur when somebody has high calcium levels. Pathological fractures and bone pain. Bones are brittle because calcium has moved from the bone into the blood. So the calcium that's supposed to be in the bone, making it strong, is leaking out and going into the blood. Stones, bones, depression, fatigue, confusion. Excessive calcium sedates the nervous system. Moans and psychic overtones, depression, fatigue, confusion. Early cardiac changes, mild hypercalcemia increases cardiac activity. Hypercalcemia, increased contraction. Hypocalcemia, decreased contraction. And the main thing we need to think about calcium is the QT interval, and hypercalcemia will decrease or shorten the QT interval. Constipation, groans, moans, nausea and vomiting, groans, moans. Hypoperistalsis occurs because intestines are sedated as well. So we've got the heart activity increasing, that QT interval getting shorter. We got the nervous system going to sleep, musculoskeletal going to sleep, intestines going to sleep. Increased urine output, kidneys are working to get rid of excessive calcium, and it could lead to polyuria. And increased clotting times, excess calcium clots blood quickly. Remember, calcium does play a role in blood clotting, muscle contraction, and cardiac, okay? So that's why we say stones, the bones, groans and moans because of things like this, and psychic overtones. They're depressed, they're fatigued, they're confused. Treatment, normal saline IV will dilute the blood, which will decrease the concentration of the calcium in the vascular space. Loop diuretics, after we give fluid, calcium will be excreted with loop diuretics, but they will not be excreted with thiazide diuretics. Obviously, if we give somebody phosphorus, we put some phosphorus in their IV, increasing the phosphorus is going to drive that calcium back into the cell. Medications that you should be aware of, the biphosphonates for osteoporosis, the Fosamax, Boniva, Actinol, Reclast. They're pretty common medications that you see patients with osteoporosis that are taking, because these medications take the calcium in the blood and put it back in the bone. That's why it's helpful for somebody with osteoporosis, and you can see that it would be a treatment for hypercalcemia. Again, excess calcium, think sedated. All right, and like I said, the phosphorus is pretty self-explanatory. Just think about the opposite of calcium. And magnesium is pretty quick and easy too. Always remember food sources too. Know some food sources that these electrolytes are in, because we have to do some teaching with patients, which is probably something that you're fairly familiar with. Okay, thank you.